Okay, so welcome back, everyone. We're excited to continue with today's sessions. So please remember to use the chat function or raise your hand if you have a question during the Q&A portion. Okay, so let's get started. So it is my pleasure to introduce our next speaker, Dr. Ronnie Kraut, an expert in the field of primary healthcare. Today, she will be speaking of her trial Optimize Plus. And joining us from the panel discussion, we have Flori Mwanda and Morgan Slater. So I'm handing it over to you, Ronnie.
Okay, well, thank you very much for the opportunity to present today. And I'm going to be talking about my trial, Optimize Plus. First, I have no disclosures to declare, except for funding from Health Data Research Network Canada for this trial. So my research question is, will a deprescribing checklist focus on easy to deprescribe medication with minimal evidence of benefit improve outcomes of residents in long-term care? So this is a pragmatic trial because it's comparing a deprescribing checklist with just a regular medication review. Originally, I was planning to do a Tylenol or acetaminophen deprescribing trial. And after a few months of looking at the evidence, as well as looking at the trial design, I decided not to do it. And the reason is because there's already quite good evidence from randomized controlled trials that are double-blind, placebo-controlled crossover that Tylenol does not work for pain in frail older adults in long-term care. So instead, I decided I'd look at an approach for deprescribing in long-term care that includes both Tylenol and also antihypertensives, which is what I'm doing a trial on right now. So first, to give you some context, polypharmacy is prevalent in long-term care facilities. There's different definitions of polypharmacy. So sometimes it's more than 5 medications, more than 9 medications, more than 10 medications. This data is from a systematic review around 10 years ago that looked at 44 studies, and it found that if you define it as greater than 5 medications, around 91% of residents have polypharmacy, more than 9 medications, 74% of residents, and more than 10 medications, 65% of residents. So polypharmacy is prevalent, it's there. The question is, why is this an issue? And it's an issue for many reasons. First, adverse effects. So polypharmacy has been associated with many adverse effects, including cognitive decline, falls, urinary issues, mood. And all of these are especially relevant in long-term care because these are key issues in this population that you want to try and avoid. Polypharmacy is also associated with medication error, which makes sense. The more you increase medications, the more chance of having a medication error. One study found of residents that had on average 8 medications, each resident had around 1 medication error in the follow-up time. Polypharmacy also increases drug interactions. So, which again makes sense, more medications, more chance of drug interactions. So with 5 to 9 medications, there's around, I think it's around a 30% chance of a drug interaction. But when you get up to 20 medications, you have a 100% chance of having an interaction between some of the medications you're taking. And lastly, there are costs. So costs don't just include the cost of the medication. There's also the cost of dispensing time. Each medication requires a nurse to dispense it. If that medication wasn't needed, then the nurse could spend their time doing other things that may be more beneficial to patient care. And there's also the environmental cost. Especially now with global warming, important to look at the environmental burden as well. So everyone knows polypharmacy is an issue. Long-term care facilities know it's an issue, physicians know it's an issue, nurses know it's an issue, pharmacists know it's an issue, healthcare authorities know it's an issue. And there have been many studies already looking at approaches to reduce polypharmacy in long-term care. This is a systematic review from 2020 that identified 25 randomized controlled trials over the last 30 years that have looked at interventions to address polypharmacy in long-term care. There were a wide variety of interventions. Some looked at pharmacist medication reviews, case conferences, computer software. Some were focused on one medication, some were focused on all medications. And ultimately, what they found in general was that these interventions work and they reduce polypharmacy. However, polypharmacy hasn't improved. It's still the same issue. This is an example of a med rec recently that I saw on a resident I admitted. So you'll notice that there's 16 medication, 13 regular medication, 3 as needed medication. This is a typical med rec I see on admission. Sometimes I get more pages, sometimes I get less, but it's typically more than 10 medication. So the question is why? We know polypharmacy is an issue. We know it's harmful. We have interventions that have been shown to work to reduce polypharmacy. Why is this still an issue? Why am I still here talking about it? And the reason is because the interventions that have worked in a trial setting. They haven't worked in a real life setting. There have been many studies looking at barriers and enablers to polypharmacy, why it's still an issue. I like this figure. It's from a study, a qualitative study done in Ireland, interviewing healthcare professionals, and shows the common themes among all studies. So barriers are insufficient procedural knowledge, people don't know how to deprescribe, established hierarchy. You have physicians ultimately doing the orders, but you have the pharmacists doing the recommendations. Insufficient time, staff, and IT support. There's fragmentation between healthcare settings. So a resident goes to a hospital, is put on more medication. They come back and you have no idea why they're on the medication and probably just stay on them. Negative social pressures. Often the feedback I get is, I've always been on this medication. Why change it now? It's worked. And misperceptions of deprescribing, especially among family, where family thinks, well, withdrawing medication means that you're withdrawing care, when in fact it's the opposite. You want to improve care. There's also enablers, and this includes education, a multidisciplinary approach, knowledge and experience to build confidence, expanding the pharmacist's role, guidelines, and a few others. So what I want to do with my approach is minimize the barriers and take advantage of the enablers. And to do this, what I want to do is a deprescribing checklist. So this checklist is going to focus on easy to deprescribe medication with questionable benefit. And ideally, this checklist will be done during the pharmacist's regular medication review. In Alberta, they need to review medications every 3 months. So instead of doing their regular review, they do this checklist, or they do this checklist in addition to their review. Ideally, I want this checklist to take no more than 10 minutes for a pharmacist to do. And this is different than typically what's done. Typically, when you talk about deprescribing in long-term care, the focus is normally on the higher risk medications like antipsychotics and benzos. This is going to be very different. It's going to focus on the easy to deprescribe medication that has questionable benefit. But I anticipate there'll still be a good effect on clinical outcomes from doing this, because each medication, even if it's not a high-risk medication, adds to polypharmacy, increases the potential for adverse events, increases the potential for medication errors, and also increases the potential for interactions. So this is a current draft of our checklist. We did this checklist. It was myself, and it was a pharmacist, a long-term care pharmacist that works for Alberta Health Services, and she does a lot of formulary work. So what we did is we looked at the top 50 dispensed medications in long-term care facilities in Alberta, and we went through them and looked at, well, what medications have no net benefit, or maybe just a minimal benefit or potential harm, and what medications are easy to deprescribe. And these are the medications that are currently on the list. So fracture prevention medications, cardiovascular medications, vitamins, bladder medications, and other medications as well. I'm just going to pause here just for a second so you guys can take a better look at the list. So I'm going to highlight now 2 of the medications on this list. First is antihypertensive. So this one is actually the subject of a study that we are just finishing. We should have results in the next 2 months. This started as my master's project and grew into a full trial, 22 long-term care facilities, 500 long-term care residents, and with a deprescribing rate in the intervention group of 75%. And by deprescribing, what we defined as deprescribing is at least a 50% reduction in the dose of the antihypertensive in 3 months. The primary outcome is mortality. The key secondary outcome is a composite of mortality, hospital, and emergency visits. And the other medication I want to highlight is Tylenol. So when I talk to people about deprescribing Tylenol, the response I commonly get is, why would you do that? Frail older adults in long-term care, they're probably in pain. Tylenol is benign. Why wouldn't you give it to them? Maybe they can't tell you they're in pain. But the studies out there that are relatively good studies, even though they have small sample sizes, have shown that Tylenol does nothing to improve pain in long-term care residents. And more than that, there's a cost involved to it. So this is a study that is currently in review at JAMDA. So a national long-term care or pharmacy provider gave us their data that includes 50,000 residents, 500 long-term care facilities across Canada, around 25% of long-term care facilities across Canada, looking at Tylenol usage. And what we found was that around 45% of residents are on regular acetaminophen in long-term care facilities. And in terms of the cost, so this is the overall table. I'm going to zoom in on the most relevant part. So in the year 2022, so in 12 months, just for these around 500 facilities, 27 million tablets of Tylenol was dispensed at a cost of around close to $900,000, around 430 tons of carbon dioxide equivalents, and around 5.6 million dispensations with around 191,000 nursing hours. So you can see, just looking at acetaminophen, there's a huge cost to the system. And then if you multiply that with all the other medication on the deprescribing checklist, in terms of a cost perspective, it should hopefully result in a much lower cost and improved care for residents, because now nurses will be able to spend their time doing other things as opposed to dispensing medication. So now getting into the trial. So the primary objective is to determine in long-term care whether pharmacists completing the deprescribing checklist during their regular medication review compared to the usual medication review will reduce hospital and emergency visits. And secondary objectives is to look at other health-related outcomes like cost of care, carbon footprints, number of medications. The trial design is very similar to Optimize BP, Pragmatic, parallel randomization, open label, and opt-out consent. For Optimize BP, we were able to get opt-out consent from ethics. So we gave families, facilities circulated notice to families, gave them around 2 to 3 weeks to opt out, and we had around 3% of families opt out their residents. I preliminary talked to ethics about this trial, and it looks like they probably will give an opt-out consent for it, but definitely not for sure. So population will be long-term care residents. Inclusion criteria are residents greater or equal to 80 years old with a limited life expectancy. Exclusion criteria, if this the patient family declines or if the physician declines. Now, I put a question mark besides limited life expectancy because this is something we still have to work out. The deprescribing checklist is meant for residents with a limited life expectancy, and that's how some of the medications have evidence of no benefit when you have a limited life expectancy, which defined as a year or less. In Alberta, long-term care residents typically have a life expectancy of around 1.5 years. So therefore, we probably need to have some type of criteria to exclude residents that have the longer life expectancy. There are ways to do this using the frailty index, using measures already in place to look at prognosis, but we haven't figured this piece out yet. So the intervention will be the facility pharmacist completes a deprescribing checklist during their regular quarterly medication reviews, and the comparator will be a delayed arm. So they'll still get the same intervention, but they'll get it 6 months later. So randomization, very similar to optimized BP. So after the opt-out period, the Alberta Health Services data analyst will randomize residents centrally, block randomization. If this becomes a full trial, it'll be stratified by long-term care facility. And then the data analyst will send the facility pharmacist a list of the residents in the intervention arm through secure email. So for the intervention, so the facility pharmacist will complete the deprescribing checklist during their regular medication review. They'll write the deprescribing orders. In Alberta, pharmacists have authority to write orders. The nurses will inform the families. So for the nurse piece for informing families, so I'm working with this with 2 professors in the nursing department at the University of Alberta, because from what we've seen, typically nurses in long-term care don't have much knowledge on deprescribing and how to let families know about it. So we're going to work on, do they need any additional education on it? Do they need a script to help them also? We're envisioning maybe like a 5-10 minute video that they could watch beforehand, just to familiarize themselves with deprescribing. And this is an important, and you may be wondering, why do nurses have to inform families? Because this is a requirement in long-term care in Alberta. When there's any medication changes, nurses, families have to be notified, and typically it's the nurses that do the notification. And then probably what we'll do is the pharmacist will send the study team the checklist for each resident with the unique participant number assigned, so it will be anonymous. That way we could keep track of whether deprescribing is actually happening. So primary outcome is going to be hospitalizations and emergency visits. The reason for this as a primary outcome is because I find working in long-term care, this is what really has the biggest impact. Yes, mortality is important, but it's those, when you have to send a resident to the emergency or to hospital, and you know they're going to be in emergency in a hospital on a stretcher for a very long period of time outside of their normal care environment, that really impacts their quality of life. So that is going to be our primary outcome. And we'll probably do Poisson regression as a measure, and we'll adjust for baseline covariates similar to optimized BP. The data source is administrative data, and the time period will be 6 months from the time of randomization. Secondary outcomes, so a whole bunch in terms of falls, mortality, cognitive and behavioral outcomes, costs of care, number of medications, and again, the data source is administrative data. So I'm going to just briefly talk about the administrative data. So Alberta Health Services has an administrative database that is very comprehensive and does include mortality as well as many comorbidities, medications in their database. And there's also point-click care. So point-click care is an EMR system that is used by all facilities in Alberta, and they track things like falls, blood pressures. So we'll be getting information from point-click care as well. So the plan is to do the pilot in 2025 at Edmonton General Continuing Care Centre. So this is one of the biggest long-term care facilities in Alberta. It has around 340 beds. They also participate in an optimized BP. And the pharmacy provider that provides pharmacy services is MediSystem. So next steps. So in March, I'm having the initial meeting with Edmonton General and MediSystem to start talking about the pilot. In April, we're going to have the protocol development meeting number 2 to finalize the deprescribing checklist and the eligibility criteria, and also work more on developing nurse education and script. In May and July, we'll develop the material for families. I'll do the ethics application, and I'll probably be spending my summer writing the protocol. And here are my references, and I'm happy to take any questions.
Thank you so much, Ronnie. So we'll now transition into our discussion. So we'll begin with questions from the panelists, and then we'll open the floor to audience questions. So panelists, if you could please introduce yourselves briefly before your first question. We'll start with Lori.
Okay, thank you, Sabrina. Thank you, Ronnie. A very nice presentation. So, my name is Fleury. I'm an assistant professor in the Department of Physiology and Pharmacology at Western University, and I'm a pharmacoepidemiologist. So, my first question was just that, first of all, as you mentioned yourself, it's just that currently, current evidence suggests that intervention used for the prescribing usually fail because they don't focus on high-risk patient and high-risk medication. So the first question I had for you was just that I was just kind of really curious, what was the rationale? I mean, I know a lot of people had asked you that question, but what is the why did you choose acetaminophen as the medication that you need to examine when you consider the benefit against the risk of all the potential other medication that are currently prescribed in long-term care facility in Alberta? I have seen the list that you have presented. Maybe I didn't get it really right, but I've seen medication like biphosphonate, statin, and all the other medications. So I wanted first of all to know, the choice of acetaminophen when you consider benefit against the risk, and also why just one medication? Why you didn't add other medication also to your list? I've seen that you have done another trial with antihypertensive, but for acetaminophen also, why you didn't add some other medication to your list?
Yeah, no, so yeah, that's a good question. So first I should clarify that originally my trial was just going to be acetaminophen, but it's no longer acetaminophen. Now it is a list of around, I think it's 13 medication
Okay.
that we're deprescribing, acetaminophen being one of the medication. And I guess the other point was why focus on these medications is because I wanted to get medications, one, that are prescribed commonly and also that are easy to deprescribe. One of the big barriers of deprescribing is that it takes time. So if you're looking at a medication like an antidepressant or an antipsychotic, you can't just deprescribe it. You have to titrate down slowly. You have to talk to the patient at each step. You have to talk to the family at each step. You have to figure out why they're on it. So it takes a lot of time to deprescribe even a simple, I find even a simple antidepressant. And that's part of the reason why it's not done, because it takes so much time. So by focusing on the easy to deprescribe medications, I think it'll be a lot easier to deprescribe, and then it might actually happen. Granted, some of the easy to deprescribe medications are relatively benign, like B12, multivitamins, but even though they're relatively benign, the cumulative effect of many relatively benign medications could have a significant impact. And not only that, but some medications on the list are not relatively benign. Antihypertensives have been linked to cognitive decline, have been linked to increased falls. Even acetaminophen, there is now evidence, and I think relatively strong evidence, that it increases blood pressure. There was a randomized controlled trial on that. And there's observational evidence that it can cause, or it increases the risk of GI bleeds, and it increases kidney impairment. So even medications that may be seen as benign probably do have some adverse effects. So therefore, by focusing on these easy to deprescribe medications, even though they're not the most high-risk medications, it will still be beneficial to deprescribe them. And I'm anticipating there still may be a difference in hospitalizations and emergency visits.
Morgan?
Hi, Ronnie. I'm Morgan Slater. I'm a research scientist at Queen's University. I do a lot of health services research, primarily in primary care. Really great presentation. And I think this is a really interesting idea. One of the questions I have is about your intervention itself. So I know that you have developed the checklist. Have you done any piloting of it? And in a second question to that is, you say that some of these medications are those that have questionable benefit. Sorry, my brain stopped working. Questionable benefit. Do you think you're going to have to convince providers of the questionable benefit, because they're obviously being prescribed by somebody for a reason?
Yeah, so great questions. we have not done any pilot work on the checklist. Like, it's something that I do routinely in my practice, but that will be the pilot at Edmonton General, in discussion with them when I meet with them in a couple of weeks, showing them the checklist, seeing them what they think, and hopefully using that for the pilot in the fall. I'm anticipating there will be changes definitely to it. This is like the sort of the first go at it. And then the other question you had about, will there be pushback? Yes, I'm anticipating definitely there will be pushback, especially to Tylenol. So it's looking at how to convince people that in fact these medications are reasonable to deprescribe. As part of the checklist, we're going to have another side that isn't fully completed yet that will have the evidence for it. So for each medication, it'll list what the evidence that shows that in fact it is either there's no net benefit, there's maybe a slight evidence of benefit, or there's harm to it as well, that I think will also be helpful.
Lori, do you want to go with another question?
Yes, sure. Renee, thank you for your response. So my understanding now is just that you are saying that your checklist list will have over 30 medication, right? If I get it right.
I think like 13.
Oh, 13. Huh?
Yeah.
Okay, okay. Is it? I don't know if you have those medication on the top of your head, but if you're not, it's okay. So my other question that I have is just that I look at your primary outcome, and what I can see is just that your primary outcome is all-cause hospitalization and emergency room visits. And then as your secondary outcome, you mentioned some other outcome like falls, fractures, all the other potential outcome. I was just kind of wondering why you didn't had also some potential hospitalization with adverse drug reaction that is related to your study medication, like acetaminophen or the other medication, 13 medication that you will have as potential primary or secondary outcome, because I was just considering that all-cause hospitalization or all-cause emergency are kind of really broad, and it may also be, even if it is randomized and you might adjust for potential baseline, but still it may be due to other reason than the medication itself.
Yeah, no, that's a very good point. We're going to be using administration data for the hospitalizations and emergency visits. So because we're using that data, it's more limited knowing the reason why. Typically, though, there is a diagnosis code associated with it. So we would be able to like analyze based on diagnosis code, but in terms of actually whether it's an adverse drug reaction or not, we're not going to be able to get that from the administration data, unfortunately. But that's a good point, that we should also look at the reasons, and at least we could look at the diagnosis codes for that. And I'll include that as well when I write the protocol.
Can I ask a follow-up question to your primary outcome? And this is maybe just me it's actually probably just me not understanding the context, because it's not where I work. Because I understand the justification for your primary outcome, like it's an important measure for the sector, that makes sense. But when I look at the list, I wonder if for some things, like artificial tears, it would be, I think, hard, maybe, again, I don't know, to link deeper, like reducing a prescription for artificial tears to a reduction in hospitalizations and emergency department visits. And so I wonder if you could explain that a bit more, and also just, if not, something to think about when you think about applying for funding, just really clarifying that rationale.
Yeah, so no, that's a very good point, and definitely artificial tears would be very difficult to link to hospital and emergency visits. B12, very difficult to link. So it's not going to be one individual medication, it's going to be the cumulative effect. So typically each resident, I'm expecting the average is around 10 medications. So if we could reduce 3 medications per resident, then that's 30% reduction. So it reduces medication errors. it reduces medication interactions, and it will reduce adverse effects. Granted, artificial tears unlikely to have adverse effects, but medications like antihypertensives, acetaminophen, all of those will have adverse effects. So it's not that one medication that will be associated with the outcome. It's rather the cumulative effect of reducing like 3 or 4 medication per residence. That's where I'm thinking we might see that difference. The other part that I'm not sure about yet is whether it'll be superiority or inferiority. So are we going to say that we will have improvement in hospital and emergency visits, or are we going to say there will be no difference? So that's the other part that is still a question.
I can go ahead, Sabina.
I was going to say, Flora, did you want to say something? I was seeing you wanting to talk.
Thank you, Renee, for your answer. So I have seen that you mentioned carbon footprints. I mean, in your protocol and also in your presentation. I was kind of really curious to know what metrics you will use to measure that, and so I wanted to. I mean, I wanted to have your thought on that, to expand a little bit on that, because I didn't really see how you would be able to do that. What would be the metrics that you'll be using for that?
Yeah, no, that's a good question. So for the study I showed with acetaminophen usage, there actually has been a well-done study that actually calculated the carbon impact per gram of acetaminophen. So we were able to calculate the carbon impact of acetaminophen based on the calculation in that study. For all these medications, though, there is a database, I can't remember the name of it now, but that calculates the carbon footprint of each of the medications. So I'm going to be accessing the database soon, because I'm preparing an abstract just on the costs of the easy to deprescribe questionable benefit medications of the top 50. And they're going to be supplying me with that carbon footprint information. So I'll probably use them as well for this study.
I had that question too, so thanks, Flori, for asking it. And Ronnie, I just want to say, like, we have the really easy job of just asking questions. So, like, again, you've done some really good work. The last question I have was just about understanding context, because I know you've said that in Alberta, pharmacists can deprescribe, and that the nurses will also be involved because they'll be notifying families. But is there also a plan to include the physicians as well? Because I assume that they would also be potentially prescribing some of this, some of the medications that the residents are on, and just making sure that the entire care team is like understanding kind of what happened and why decisions were made, so that, you know, the pharmacist doesn't deprescribe and then the next day, like, I go in and decide, like, wait a minute, why did that happen, and put them right back on the meds.
Yeah, no, that's a very good question. So with Optimized BP, we had a physician component where basically we notified physicians about the study, and then we also gave them an opportunity to opt out. So if they didn't like the idea of reducing antihypertensives, or they had specific residents they didn't want it done on, then they could opt out. And we'll very likely do the same thing with Optimize Plus as well. Give physicians the chance. They see the checklist. If they just don't feel comfortable with it, they can opt out. And for Optimized BP, we had some sites where the pharmacist was fully doing the deprescribing, and they would just write the physician a note when they deprescribe. Whereas other sites, it was the physician would make the recommendation. No, the pharmacist would make the recommendation. The physician would ultimately sign off on it. So I anticipate for this study, it may be similar. It may be some sites, the physicians will be like, no, we want to sign off, and they'll sign off. Versus other sites, it'll just be the pharmacist doing it. For Optimized BP, sites where the physicians were not involved had a better deprescribing rate than sites where the physicians were involved. So we may sort of encourage facilities to just have pharmacists do it as opposed to the physician signing off. But if physicians do want to, I think we'll have to give them that option.
That's fair. And can I just ask a follow-up question? And sorry, I don't know if you know this off the top of your head. I wouldn't expect you to, but do you know how many physicians in your previous trial decided that they didn't want to participate? Was it a big number? Okay.
It was maybe I think it was 1 or 2.
Okay, that's great.
I don't know how many physicians there were in total, but of the 22 facilities, there was 1 or 2 physicians that decided they didn't want to participate. However, having said that, there were several facilities where physicians didn't opt out, but then when the pharmacist wanted to deprescribe, the physician said, no, we don't feel comfortable with it. So it probably would have been even better if had more physicians opted out, because then you ran into a situation where someone was randomized already and we couldn't deprescribe because the physician said no.
Yeah, okay, thank you.
Yeah.
Laura, did you have any follow-up questions?
Yes, so it's the last question, for sure. So, Ronnie, so my question is, so definitely your population of interest is people with, I mean, in the long-term care, and definitely as you say yourself, there are definitely people with polypharmacy. So my question was just that within that population, we definitely know that also the prevalence of individual with renal impairment will definitely really be really high. So the prevalence is definitely high. So I was just wondering if you plan to do kind of subgroup analysis in people with, renal impairment versus no renal impairment or something like that with different EGFR categories as well, just so that you can really target the population that may benefit the most with the intervention that you are developing in the deprescribing.
Yeah, no, that's a very good point. And I'm going to make that as a note of something to include to do subgroup based on renal impairment. We easily will know residents that have renal impairment versus not, because we'll have access to their lab results. So that should be relatively easy to do.
And Ian, did you have any last questions? No? Okay. So now we'll start taking questions from our audience. So if you have a question, please use the chat function or raise your hand and come off mute. So I see a question in the chat. So Ahmed, apologies for missing this, but is this trial only being conducted in Alberta or are there other provinces?
So the plan is only Alberta, because just based on, there's enough long-term care facilities residents in Alberta to do the trial. But if successful, then I know the pharmacy operator that's doing the pilot has said, this seems like a great idea. We should roll it out to other provinces. So if successful, potentially rolling it out to other provinces, but only doing the trial right now in Alberta.
I have a question. So I'm a rheumatologist. So when I was looking at the list, I saw the bisphosphonates and the calcium and vitamin D. And I guess that after 5 years, it's true that for most patients, it would be okay to be prescribed. But let's say a very high risk patient who had a really recent fracture, and then there will be other considerations, or like the eye drops. Usually, but I'm thinking about Sjogren's, the patients who have really severe eye disease. So is there any consideration that will be put into the medical chart and the medical history? And when you consider having the option of opting out for physicians, will this be the general practitioner, or will you be reaching out to the specialists, the different physicians for each type of medication? Maybe different physicians that are prescribing with different indications within this whole list of medications.
Yeah, no, that's a very good question. And the intent of the checklist is to be easy and take no more than 10 minutes. So if, as we go through the pilot or before the pilot, and there's a lot of issues with the bisphosphonate saying, well, there may be some high-risk people, and we're going to deprescribe them because we're just going to check it off and not realize they're high risk, we're going to take it off the checklist. So it's any medication where that's not possible for like 99% of people to safely be able to deprescribe without a lot of looking at previous history or discussion. We're just going to take it off the checklist.
Shab in the chat asks, how do you ensure that the observed outcomes, hospitalization or ER visits, are attributable specifically to the application of this deprescribing criteria rather than being influenced by pharmacists' clinical judgment, experience, explicit criteria such as Beers criteria or implicit criteria, or patient-focused medication reviews?
Yeah, no, that's a very good question. I know there are a lot of criteria for deprescribing, but it's not being done. So I think it's safe to assume that if there is a decrease in hospital and emergency visits from residents in the intervention group versus the control group, it's probably the deprescribing checklist. But we probably will need to, when we onboard facilities, we could probably have that as a question. Are you doing any deprescribing work, right, quality improvement work right now? So we know for sure that it is or isn't being done. So we could be more confident that if there is a difference, it's because of the checklist.
I don't see any other questions in the chat for now, so I could ask another question. So you mentioned that many other trials have been done, and there has been some difficulty with translating or applying the results of the other trials into practice because of multiple barriers. So what is your plan in terms of ensuring that your results will be applicable to practice?
Yeah, no, good question. So one thing is just the intervention itself, the intervention not being something that's cumbersome, because often with deprescribing, it's not just let's take someone off the medication, but it's rather let's have a case conference and talk about it. Let's review charts, let's talk to family, and then we'll do it, which is not feasible in the current environment. So this checklist should hopefully circumvent all of that. It's just looking, are they on the medication, looking at a simple lab result, and then checking yes or no typically, or looking at blood pressure, checking yes or no. So I think that's going to make it a lot easier to implement into long-term care. And we'll see how it goes. If it actually is effective, it actually only takes 10 minutes and it actually does reduce costs, reduce hospitalizations, then I think there'll be a lot of interest in among long-term care facilities to implement it.
I believe anyone else has questions, don't be shy to raise your hand. Victoria asks, are you looking at all-cause hospitalization as a part of your composite outcome, or will you restrict to non-elective hospitalizations, like excluding hospitalizations for elective surgery? And this is Amit's question actually.
Yeah, no, that's a good question. For optimized BP, we did just do unplanned hospitalizations, and it is possible to get the unplanned hospitalizations and emergency visits from administrative data. So we'll do the same thing for this study, just focus on the unplanned.
I had a question on the opting out. There was, you said there was another study where the physicians could opt out, but I guess that when you say that it's, if you get opt-out consent approved by ethics, that would be at the patient level, that the patient would be able to opt out, and with long-term care, and then there's a conversation with the nurse and the family. So how do you see how it's gonna roll out in terms of opt-out?
Yeah, so what I'm envisioning is that before the study starts, families are given the information about the study, and they're given around 3 weeks to opt out. And typically they'll be given a phone number they could call if they want to opt out. And at the same time, physicians also are given around 3 weeks to opt out as well. And then once we know who's opted out, then we just select the rest of the residents that are eligible and randomize them. Does that answer your question?
Yeah, so and the physician, it's the family physician or all the physicians involved in prescribing these medications?
Yeah, so long-term care, different than primary care, is really, it is only the physician, the attending physician, that prescribes the medication, which makes it easier. So you don't, a resident, at least in Alberta, doesn't have a specialist prescribing medication. It's only the attending physician in the long-term care facility that's prescribing all their medication, which will make it a lot easier to do the study.
I don't see any other hands. This session was maybe a little bit shorter just because we had 2 panels instead of 3. So unless anyone else has burning questions, we could wrap it up. So we could wrap up our question and answers here. So thank you so much, Ronnie, for sharing this trial with us. And if ever, yes, okay, there's a clap. I thought it was a hand raise, but it's a clap. So there's another question. Sorry, so we're not wrapping it up yet. So will you be looking at any adverse events from the intervention, for like if there's reduced acetaminophen, if do you see more opioid prescriptions?
Yeah, no, that's a good point. For optimized BP, we did look at that also in terms of what is the total medication. So we could definitely, again, I haven't done the details of the protocol, but definitely that's a good point to look at specific medication classes that we may anticipate there may be an increase of because we're reducing other medication. I know that I think it's unlikely there'll be an increase, but definitely we should look at that to make sure that there isn't.
But as a follow-up question to that question, is there any plan on looking at represcribing? Like if it's deprescribed and then there is pain and then it's represcribed, or the eye drops are removed and the eyes are really dry and then they are represcribed, how would you capture that?
Yeah, so for optimized BP, that was a concern also, is that yes, we're reducing the antihypertensive. What if it's represcribed? So we were able to capture that with administrative data. I can't remember the algorithm we used, but we were able to look at, well, have there been any other antihypertensives prescribed since the last one was deprescribed, or has that one been prescribed again? So we could for sure do that with this as well. Look at it at a later time point and see, are they still off the medication or are they back on it? And that's also important to see, is it actually lasting or not?
And just a follow-up to that as well, let's say bisphosphonates and calcium vitamin D, if it's deprescribed and then there's fracture, for example, then I guess that would be captured as an adverse event, but in the outcome in terms of the balance of the risks and benefits. There's a question from Yasmin. Do you have any specific protocol to substitute acetaminophen like topical agents?
Sorry, can you repeat that?
Do you have any specific protocol to substitute acetaminophen like topical agents? Yasmin, I don't know if you want to clarify the question.
Yeah, thank you for your presentation, Ronnie. I was wondering if you are planning to have a protocol to suggest an alternative that could have more effectiveness, like topical painkillers, NSAIDs, or whatever.
Yeah, so that raises a really good point in that the assumption is people are on acetaminophen because they're in pain, but in fact, often it's a legacy prescription. So these people were in hospital, they had something happen, they had an injury, they were put on acetaminophen. That acute event resolved. Now they're in long-term care, but the acetaminophen hasn't been reevaluated. So I would say for most people, it's not that they're in pain, that acetaminophen is helping with their pain, or they're actually in pain. It's just a prescription that had been put on and hasn't been reevaluated. in my own practice, I take people off acetaminophen all the time. There's never anyone that says I'm in pain. So it's not that they're in pain and they're on acetaminophen. It's rather that they had been in pain, they were put on acetaminophen, and now they're not in pain anymore. And they're still on acetaminophen. That's typically what I see. But I think, again, it's looking at the one, having evidence to be able to convince people of that, so they're fine with deprescribing acetaminophen, and two, having another outcome, so that way we can actually see our opioid prescriptions increasing more, our topical NSAID prescriptions increasing more, to make sure that we could say they aren't.
Eric asks, are there any issues with opt-out consent in patients who may not be competent?
Yeah, so most patients in long-term care can't make decisions on their own and have a family member that is making decisions for them. So we were able to get opt-out consent for optimized BP in that situation. So I don't think it's going to be an issue with this study in terms of the fact that residents aren't confident, because we were able to get the opt-out consent for the previous study with very similar types of residents.
I don't see any more questions in the chat. So if you have a question, manifest now, or we're gonna close the Q&A. So that concludes today's session. So a big thank you to Pavel this morning, Ronnie, and our panelists for their contributions. We appreciate everyone's participation, and we look forward to seeing you tomorrow for day 3 at 11 Eastern Standard Time for more expert conversation from Dr. Yang Su and Dr. Anne Young. So have a great rest of the day, and see you all tomorrow. Bye.